Hi, everyone. Great to see you. Happy Wednesday. Hope you have better weather where you are. We're having some intense thunderstorms at the moment, but it's providing a little suspense for our session here today. Thank you so much for joining. I'm super excited to have Sohail here scribing for his first time. Yay. Thank you, Sohail. And Mariana will be doing teaching points. And Brett, I saw you're our case presenter today. Do you want to say hi to the group and tell us your brief life story?
Hey, absolutely. Hi, everyone. My name's Brett. I am currently a PGY2 resident in internal medicine here at Emory. Grew up in Louisiana, love to cook and hang out with my wife, and I'm just happy to be here. Excited to present my first case.
What's your culinary special, Brett?
Ooh, good question. I like to cook a little bit of everything, which sometimes has either good or bad results, depending on how how new it is to me. Italian food is definitely my specialty, though.
Nice. And do you have a go-to for recipe source or just
Uh,
anything that strikes you online?
so typically my dad's actually a chef. So
Oh,
I get to
wow.
piggyback off of his powers as opposed to my own.
Is that a little bit of pressure in the kitchen then? Like,
Fortunately, no, just because he always cooks for a living. So every time I visit now, he just wants to go out to eat. Doesn't, it's more of a job at that point. So
yeah,
fortunately, I don't need to, fortunately, I don't do it myself. I mean, I don't have to compare directly.
yeah, that helps. Awesome. Well, super excited. Zaven will join. Let me see if he's on yet. At some point, he's kind of on the move between multiple teaching sessions today. So, would love to know if anyone in the audience wants to kind of join me as a main discussant today. Would love some input. Deborah, I missed Deborah. Did you want to? I saw Deborah in the chat said you love pasta. I didn't see that you want to chat, but that would be amazing too. I love discussing cases. Wish we had pasta to do it with. You want to join me?
Yeah, let's do that.
Amazing. Um, Let me see if Zaven is on and if I should stall a little more. Nah, let's get started. We can catch him up when he comes on. So Brett, if you want to, oh, I guess Deborah, do you want to say hi to the group and give your brief life story?
Hi, everyone. I'm Deborah. I'm a CPS Solvers team member. I work a lot on the IMG project. We will start soon. Everyone that will apply this year, we have a lot of good sessions to help. And I participate too on the clinical know of the podcast. And yeah, I'm excited to discuss.
Awesome. So excited to have you here, Deborah. All right. Brett, want to take it away?
Absolutely. So the way I'm planning on doing this is we're going to present 4 to 5 aliquots, and we're going to kind of present the case how it occurred in real time from the outpatient setting and then into the inpatient setting. So we have a 58-year-old gentleman. Previously, he was a relatively healthy guy who presented to clinic for evaluation of 6 weeks of progressive decline in an exercise tolerance as his chief complaint. So briefly, really the only information you have before you even start the visit is that he had really no significant ongoing medical problems. The only thing you see that he'd been actively being worked up for was a new onset persistently elevated transaminitis that had been really noted by his PCP over the last month, just with some routine labs. Had no medications that he was taking, did not any herbal supplements, no prior history of hepatitis or high risk exposures, no significant alcohol use, no abdominal pain, swelling, distension, or really any other symptoms. He'd undergone an ultrasound that had demonstrated only evidence of some reactive lymph nodes within the porta hepatis. It referred him to hepatology. He had gotten an MRI of his abdomen and had plans for a future MRCP. That's essentially where we're at before we dive into the into the HPI. So I'll stop there briefly.
Awesome. And Brett, I'm so excited just to hear the real life evolution of that's so common, right? People have some outpatient workup that we on the inpatient side kind of just pick up from and really depend on for kicking things off. So I'm excited about this already. Deborah, what are your thoughts?
This is a really interesting tooth complaint. I really love exercise, so I would definitely want to know more about this patient, what kind of exercise he used to do, for how long time, if it's something more, if he runs, if he, I don't know, do cycling, and then now he's not being able to do that, and definitely make me think about the lungs. If this, I don't know, if he's having any shortness of breath, I will ask are you able, I know you're talking here about exercise, but is he able to do his daily activities? Like if he is having I don't know, some shortness of breath of I don't know, getting up in the stairs or walking 100 meters, how is he feeling? And asking how, let me see, no prior hepatitis medication. Yeah, and definitely make me think about the lungs. If could be maybe in anemia, take a look on the hemoglobin. I think that's where I would start.
Yeah, I love that. It's, I think this is a very real life case already because we know his concern, right? He's coming in for this decline in exercise capacity. And yet, right, hulking in the background is all of this hepatic workup. And it's really easy to start focusing and dig on that. But I actually really applaud you, Deborah, for saying all right, let's figure out what this guy's symptoms are from first. And then we can look at the objective abnormalities that have been found and figure out what they are and how they tie in. And I think you asked some key questions, how, and maybe Brett, you can fill in a second, how profound is his kind of exercise related difficulty? I think there's a whole spectrum, right? It could be someone who runs 4 miles a day and he still can run 4 miles a day, but he's noticing he's more winded than he was, or someone who wasn't particularly active, but with the exertion in his house, like you said, with doing stairs, it's more prevalent. I would say both are really worrisome. Certainly if he was very active and then suddenly impacted in just days of leaving, that suggests a severity that's there. But I've tried to sort of just be aware of even more subtle exercise tolerance because I think it's easy to miss, and this is anecdotal, but I think people who start in a fairly fit place and notice something is off, there's some potential there for diagnostic delay because they don't sound that bad, right? But it's all relative. So Brett, do you mind what did he say in terms of what's harder to do for exercise?
Absolutely. So in the clinic itself, he says that previously at baseline was very active, ran about 5 miles every day on average. Very good exercise tolerance, but for these last 6 weeks, it progressively became more dysmorphic with exertion to the point where now he can only run about 100 yards without having to stop and take a rest. He had, going into this is all very new, although he does state that about 2 years ago he had one episode of post-exercise syncope, never was evaluated, had really never had any recurrence of that. During this current episode, had some lightheadedness also with the exercise, or really any significant exertion around the home, lifting heavy things, etc. He denied any associated chest pain, but instead, following exercise, he would have some pain in his jaw, neck, but also interestingly in his knees and shoulders with some associated cramping. Has had an intermittent dry cough, but otherwise denied any palpitations, orthopnea, P&D, no lower extremity edema, no fevers, chills, recent sick contacts, or wheezing, and denied any recent rashes, skin changes, and essentially the rest of his review of systems at that point was negative.
Oof. So there's actually quite a bit going on. Maybe we can kind of divide and conquer a little bit. Zaven, give us the word if you're in a place where you're ready to chime in at any point. But I guess want to close kind of your thoughts, Deborah, on just this exertion. So his exertional capacity has changed a lot over the 6 months, 5 miles to 100 miles a day. And I really like, Deborah, that you just kept it very open. I think generally the framework that we use for dyspnea in its many categories, including cardiopulmonary, as well as kind of musculoskeletal rated, as well as blood problems, right? Anemia, et cetera, are all very much on the table here. Now we're starting to hear the history enriched with some exertional syncope and cough that may make us really expand on the cardiopulmonary basis where to begin. But exertional fatigue like this, huge differential diagnosis that I think we can layer onto our dyspnea pyramid well. before we get into some of his other symptoms, we haven't sort of tackled any of the hepatic abnormalities that have already started having a workup. Deborah, do you have any thoughts? And Zaven, I'll just quickly summarize. He's had mild, correct me if I'm wrong, Brett, AST, ALT elevations that had an initial workup with hepatitis serologies, and then imaging showed porta-hepatis lymph nodes. Is that right?
And I can go a little bit further.
I'm sure
I
you
had
can
it
get
kind
more
of
into
recorded
that.
later. Yeah,
That's okay,
but
yeah.
at this point, we'll say an ALK phos predominant mild transaminitis, including his AST, ALTs, and overall, aside from some lymph nodes and the porta hepatis, and his from a right upper quadrant ultrasound, was really kind of the main points we had at this point before we dived too much in. But that was kind of the extent of his liver involvement.
Yeah, so we already on this first primary care visit, that's still, I think, where we are kind of cognitively. We've got this exertional fatigue that's really concerning. And then, yeah, these AST, and mild ALK phos elevations with some lymphadenopathy. We'll hear certainly a lot more about that. But kind of, Deborah, any just thoughts on like in a clinic, how would you even start sort of approaching AST, ALK phos for figuring out what's going on?
Yeah, like definitely I would think maybe could be something acute happening, like the ALK phos was elevated 1 month ago. So definitely do more lab exams to try to check, starting actually from hepatitis, to see if the patient, like in, I don't know, hepatitis A, B, C, the most commons, and do more imaging to see if we have something in that we can see in the liver, and definitely like go for an EKG and chest X-ray to see why this exertion. And that were my thoughts.
Beautiful. Yeah. I'll just layer on a couple comments on working up abnormal liver tests. The first is a lot depends on the pattern. And the kind of 4 patterns that we think of usually are hepatocellular, where the most abnormal liver tests are the AST/ALT. There's cholestatic, and that's when the most abnormal is in the bilirubin. And I'm saying most because everything can be abnormal. The question is, which lab is predominating? There's a mixed pattern where it really fits very well in between AST/ALT and the billies being elevated. And then when the ALK phos is high out of proportion to the rest, that's what we call a infiltrative pattern of liver injury. When you have an ALK phos elevation, you do want to make sure it's coming from the hepatobiliary system, and tests like a GGT, or some hospitals can fractionate the type of ALK phos you have, can verify hepatobiliary is the source because it can come from bone and other places. But if it's predominant ALK phos elevation, that opens up a whole category of infiltrative conditions. I think off the bat in a primary care outpatient clinic setting, the low-hanging things to really think about are chronic hepatitis, as you already said, Deborah, any meds or toxin exposures, and this has been a pretty healthy guy, but has anything new started, right? Has he started taking any Tylenol? Has he started taking any herbal supplements because of his symptoms? Family history, I think, is really important off the bat here to help figure out early on, are we going to start going into some of the category of familial ones? And then, of course, fatty liver disease is extremely common. And then I learned a few years ago that like celiac disease actually can initially present with just a mild hepatopathy. So when you're first seeing things that are really common in primary care clinic, thinking of the hepatitis, drugs, familial conditions, and then I'd actually put celiac in there as kind of quick things to sort of take off the list. Brett, we could talk a lot more about what we have already. What do you want us to dive in a little more now into the exertional kind of syncope symptoms, which we haven't unpacked yet? Or do you want to give us a little more story? Up to you.
So I think that we can do a little bit of both, and we can I can elaborate a little bit more, then go into the third aliquot. So talking with him, seems like this, as far as one time, syncopal component was, like, as I mentioned, 2 years ago, had never had an occurrence. And here was more of just lightheadedness following that 100 yards with the significant dyspnea, and really had no other kind of interval symptoms aside from the associated symptoms we kind of discussed. And then to y'all's point about, starting with some of our basic workup, as at this point that we had gotten an EKG in the clinic that demonstrated a heart rate in the 40s and a high grade AV block. So he was transferred to the hospital as a direct admission for further workup. And then we can move on to kind of aliquot 3, where at that point, we confirm his HPI, and then to fill in some of your other details and questions. As far as a past medical history, really just bilateral cataracts and hyperlipidemia. He had also a reported recent unclear allergic reaction several months ago with a rash on his leg that he had gotten some topical antibiotics from a local urgent care, seen by dermatology, who gave him a topical steroid, and then those symptoms improved, but really no other significant past medical history. Medications and supplements, as we already discussed, he was taking nothing chronically, no significant surgical history, no family history of any cardiovascular disease or any liver disease in any of his immediate or family, no allergies, and from a social history, denied any tobacco use, no alcohol use or drug use, lives in the Atlanta area, but does travel intermittently to visit family in Rhode Island and New York. But last time was several months ago. And then I'll go into vitals and we can kind of wrap up there. So whenever he came in, does a direct admit, his vitals he was afebrile, a temperature of 98. His pulse was 45. His blood pressure was 98/51, sitting at 97%, and a respiratory rate of 18. On physical exam, he was well appearing. He had no significant HENT abnormalities, no sclera, sublingual icterus, no conjunctival pallor. He had no lymphadenopathy. He was bradycardic, but had normal heart sounds otherwise. No peripheral edema. Lungs were cleared auscultation bilaterally. No rashes. And on his MSK exam, had some moderate tenderness with passive range of motion of his left knee, but was non-erythematous. There was no significant swelling. And his neuro exam was also completely intact and non-focal.
Awesome. Thanks, Brett. Deborah, what stands out to you? We got a lot more info. What do you want to tackle?
Yeah, this EKG, like if he has like a low heart rate, I think like because he do a lot of exercise, athletes could have like a low heart rate, so that doesn't bring me too much attention. But the AV block make me think if it could be like infiltrative, like in the heart and in the liver, something like sarcoid, Lyme, amyloidosis. And then I think Braid said that he had some steroids and then the symptoms improved. So maybe that if I didn't heard wrong, I think if that could maybe, I don't know, maybe be sarcoid and sarcoidosis, and then the patient like can significantly improve with the medication.
And correct us, Brett, if we're wrong, this was topical steroids for the leg rash.
Ah, okay.
Correct.
But
Correct.
Okay, sorry.
yeah, you're already making great strides, Deborah, just thinking about we've got a cardiac, and now we see there's a conduction problem here. We have, again, the abnormal liver panel, and I really like that sort of overlap of, oh, like what can get in the tissue in both of those organs to cause these problems. A general clinical reasoning point, I think we've done in a lot of these exercises problem representations where, it just helps us frame. And I think another way to do the same processing of what's going on and really naming what you're working on is also just by making a problem list. So I think before we sort of move forward, it would be really helpful to let's get our problem list out there for this guy, and then we can see if there's other areas that we want to jump in there. Zaven, your video's on. Hi.
Hey, how's everybody?
We're good. So let's do this. And we won't put Zaven on the spot because he may not have heard all the case, but
No, I'm good.
do you want to help us? Do you want to do the problem list then? Like there's just so much going on. I kind of want to make sure we have it all out there. We'll see how it intersects, but I think actually naming what we're working on is such a priority right now.
Yeah. Okay. I do think actually, well, can I just share sort of like from the perspective of someone who just kind of like jumped on a few minutes in and was just sort of listening to the new information trickle in while somewhat distracted, and thus like, I guess, only allowing like the most notable things to even register. Maybe that can be a helpful perspective. I think first when I just heard like decreased exertional capacity and LFT abnormalities, for some reason with that frame in my mind, I was thinking more that there's anemia, just because of the very wide overlap, I guess, of things that can affect the liver and then cause anemia. Celiac, Steph, you mentioned being one of them, for example. But then the exertional syncope was definitely a red flag for me. I think that just shouldn't happen, and to me does invoke like a cardiac problem, be that a structural cardiac problem or sometimes a rhythm cardiac problem. But exertional syncope is always a red flag to me, and that totally sort of reframed as like, okay, there's something with the heart, and then the LFTs, who knows? Maybe it's congestion, maybe it's something else, but like focus on the heart. And then the other thing that I guess had been said in the first few minutes when I wasn't here yet, but then someone was kind enough to repeat, was that the ultrasound had showed lymph nodes. Suddenly, when it's heart and lymph nodes, or exertional syncope or lymph nodes and LFT abnormalities, especially alk-phos, suddenly the focus shifted completely again to either a malignant or infiltrative kind of categories of disease. Infiltrative including, sterile inflammatory stuff like sarcoid people are invoking, as well as granulomatous fungal infections, things like that. And then the bradycardia to me sort of was critical. And I guess in this process of discussion, I'm also listing the problems, but maybe the order of priority is now almost in reverse of, bradycardia and exertional syncope, lymphadenopathy, LFT abnormalities, and then the exertional dyspnea is almost like parenthetical to me at that point, because whatever can cause bradycardia and exertional syncope can cause exertional dyspnea, right, or exertional limitation. So it's sort of swallowed by the more specific problem. And I guess to the last point of this was an interesting question. I think, Deborah, you mentioned of like, he's a fit dude that until quite recently, a month ago, was running 5 miles, right? So his sinus bradycardia at rest, just sort of vagal tone and reflect that cardiovascular fitness. And I'm actually not sure, like, if you are fit and have baseline sinus bradycardia / just a slow heart rate that's physiologic, and then something happens that makes you lose your fitness in terms of like you can barely run 100 yards now, right? You're no longer really fit, are you? So then does that like resting lower heart rate also go away with that? And how quickly? And I would guess yes, or at least like in a patient who's clearly like something's going on that's kind of serious. If their heart rate is just 45, like they're just that to me is signal. I might be wrong, but to me, I think that might be part of the equation of something as you were mentioning, infiltrative, sarcoid, whatever, affecting the conduction system or otherwise impairing what should be, I think, a slightly higher, sympathetic tone, slightly higher resultant heart rate, even at rest. So that's where I would land now of, inappropriate bradycardia, exertional syncope, and then maybe intra-abdominal lymphadenopathy and possible infiltrative or mixed pattern of LFT derangement.
Yeah, I love that. I think that boils things down well. How much this steroid responsive rash fits into it, we'll see. But for me, that's kind of a fourth, very, very lower priority problem compared to the rest. But Deborah, you made some good connections early about a lot of these systemic conditions that we've talked about, like can manifest in the skin also. So we'll see. Did we tackle what we want to on the physical exam? I guess Brett, the heart rate is slow and regular when he's pulse is felt or as it's monitored?
Correct.
Okay. You want to take us forward?
Yeah, absolutely. And so then with all that being said, going into some of his more objective data, so his white blood cell count was 7.8 with a normal differential. His hemoglobin was 11.1 and his hematocrit is 34.3. His platelets are 222. His CMP was essentially completely normal with the exception of an AST of 58, an ALT of 84, and an ALK phos of 240. And he had a normal bilirubin. His troponin and BNP were both normal on admission, as was his TSH. He had a mild elevation in his ESR and CRP at 42 and 46.7 respectively. He had an EKG and a tele, as we already discussed, that demonstrated second-degree AV block that then eventually progressed to demonstrate complete heart block. And then he had a TTE with an intact LVEF and no evidence of any obstructive physiology on that or any abnormal gradients. And then just to touch on some of those labs that we had in the EMR from his prior workup with the hepatologist, his MRI had of his liver had abnormal non-specific liver enhancement that could suggest underlying inflammation. And then the remainder of his workup was negative, including negative hepatitis studies, alpha-1 antitrypsins, negative smooth muscle antibody, mitochondrial antibodies, ANA, and it was his bone-specific ALK phos was negative, or normal rather.
Awesome. Thanks, Brett. Deborah, maybe we can divide and conquer a little bit. Do you want to, just with the initial lab evaluation that he got, tell us what you're thinking? And maybe, I mean, we're seeing a great differential diagnosis in the labs that were checked. Maybe you could share your thoughts about why you think the team kind of checked them and how they're helpful. I can talk just a little bit about kind of complete heart block and where that takes us. And maybe Zaven, then if you want to sort of layer on the hepatic, the liver imaging and see if that gets us anywhere. But what do you think the labs, Deborah?
Yeah, I think we didn't we get more negative things so the hepatitis was something that I was thinking with the elevated transaminitis that this patient was presenting, it could be like an infection. But even that is negative, that doesn't rule out. Many times we have negative labs and then even the patient have the disease. And the ENA, anti-smooth, anti-mitochondrial, going for the autoimmune hepatitis, that could be something that the team was thinking about it that came negative too. So yeah, rolling out those two, definitely other more, definitely maybe, I don't know, other an ANCA to see if there is any vasculitis ANCA related and another thought that we had recently, you and Zain discussed a really nice case of Lyme disease, and maybe think about that too. That will be my thoughts right now.
Love it. Yeah. That was a really cool case. And yeah, I think just thinking about heart block in general, I have a very simple way to think about it. And that is either something's wrong with the heart itself, and we can talk about what that is, or something external to the heart in the body is causing heart block. We've mentioned in our discussion already some of the kind of intracardiac or intrinsic to the heart problems that can cause this, right? Infiltrative disease like sarcoid, amyloid, hemochromatosis has come up in our discussion in the chat. But let's zoom out and say what would be most common? Well, what most common would be like conduction system disease, whether from prior scar and MI, which we know this gentleman doesn't have, or just general fibrosis over time, which is why, right, often when we're managing this, at least in the hospital, it's older patients. So is there conduction system disease from changes? Ischemic heart disease, we know with his negative troponins, and also this long history that this isn't an ischemia right now to the conduction system, but that is a common cause also. I think those are the main things. Outside of the body, though, outside of the heart, a lot of stuff can do it. You mentioned already an infection that can, so Lyme carditis can, certain viral myocarditis etiologies can as well. We know based on the normal labs, severe electrolyte disarray is not going on here, but profound hyperkalemia can cause heart block. And then we have a normal TSH, which is so helpful because severe hypothyroid disease can cause sinus bradycardia, but in profound cases, it can actually cause heart block there as well. I would also consider in that outside the heart category, any meds or toxins that he could be taking or could have been administered, and anything procedural, which isn't relevant in this case, but again, can happen a lot in the hospital if someone's just had a valve replacement or a catheter ablation of anything. So I think in him, a lot of these things we know by history are not likely. I am worried now about primary cardiac problems, knowing a lot of the initial labs and findings don't support another systemic process that would cause heart block as a bystander. And so even with the normal echo, I think we might have to get more specific with more advanced cardiac imaging to see what could be at play there. Zaven, do you want to tackle anything on the heart block or add any thoughts on the liver imaging?
Not really. I think that was a great outline of thinking about the heart block, and you sort of mentioned a very comprehensive list of causes that in this case weren't relevant, but I think all the ones that have been mentioned as more contextually likely here have such a perfect sort of propensity of explaining the liver at the same time that I think it's all part of the same discussion. The liver may be a part of the answer in terms of sampling if it ever comes to that, but otherwise not really anything else to add. Deborah, how about you? Did you have any other thoughts?
I don't think so. I think, yeah, maybe thinking about the liver biopsy, that is my thought right now.
Yeah, maybe we'll see what Brett gives us. Should we come up with a wish list of what we're going to do next? I'm curious about more advanced kind of cardiac imaging, right? Knowing the echo was normal, but we're worried still that the heart muscle may not be normal. Deborah, sounds like you're like wondering about tissue at some point, huh?
Yeah, and something that I was kind of forgetting, this lymph node, if the patient has any lymph node in the body, if like maybe do a CT to check the lungs or the abdomen to see if there is more, was another thing that I was thinking.
More, and like, is there somewhere more easily accessible than intra-abdominal? That's a great point. I love it. Brett, what do you got for us?
So going into kind of as the hospital course progressed, so I shared a lot of y'all similar concerns as far as an infiltrative etiology. So we got a cardiac MRI that did not demonstrate any sort of infiltrative disease. So essentially was structurally normal without any sort of late gadolinium enhancement or any other abnormal findings with that. At that point, he continued to be significantly symptomatic intermittently at rest and continued to have intermittent complaints of different myalgias and arthralgias on the admission. He had gotten a permanent pacemaker placed, given the degree of his symptoms, by EP. And then at this point, as he was actually, at that point, the majority of his workup had come back negative. And as we were waiting for some labs to be placed, as I mentioned, we gave him the permanent pacemaker. And actually, as I was the one tasked with convincing him he was, we can follow up the rest outpatient, his Borrelia burgdorferi serologies came back positive.
Wow.
Both IgM and IgG.
Deborah, Zaven, thoughts?
Wow. I really like the episode, sorry, because you two recently have a case of that you presented how could be the heart manifestations of Lyme. If you want to explain for us, I really like that teaching point that you share, Steph.
Was it me? I was like, oh,
yeah,
that's a great teaching point.
it was you.
Yeah, so cardiac manifestations of Lyme disease, can almost sort of think about it through the layers of the heart, almost being kind of anatomic about it. Starting on the outside, I mean, you can get a pericarditis from it, and that was not at all the clinical syndrome that this gentleman was going through, but you can get pericardial inflammation that can extend to the myocardium also. So there can be a myopericarditis, which is important because in pericarditis, right, it would be the classic syndrome and ECG findings, not a troponin elevation, but if there's myocardial inflammation there as well, that's possible. Kind of moving a little closer through the heart muscle, right? The conduction system goes through. And so we're seeing here that this is a likely explanation for him having had a complete heart block. And then if the whole muscle is actually sick, you can develop a cardiomyopathy from it. So really sort of affecting all layers of the heart. But let me just put a caveat and see if the group knows, because I haven't seen a lot of Lyme recently. Can it all the way go to endocardium and cause an endocarditis picture? That I'm not actually sure of. So we can learn from someone if that's the case. So I may have to step back and say not necessarily every layer of the heart, but almost every layer if endocarditis isn't there. Yeah. You know, we kind of like didn't think a lot about his knee pain that he had. Just as you said, Brett, he like kept having these aches and pains. And in retrospect, right, it's important for us to put that together. But it's also making me realize like that happens a lot in real life, right? You're like, dude, you're here with heart block. I know your knee hurts, but like let us get your heart kind of beating regularly again. But this is such a good reminder that some other concerns that we may not be as worried about can factor in, really well there also. Do you think in retrospect, Deborah, there were other elements of the case that kind of could fit?
I don't think so. Actually, that was a good question in the chat. Like Austin asked if the Lyme could explain the liver, and nothing. I have to read more about it because I don't think so, and definitely was not thinking with the dyspnea. Yeah, and definitely like the arthralgia and myalgia, that's something that brings my mind for Lyme. But I'm learning Lyme, so I'm from Brazil, so we don't have Lyme there, so it's kind of new for me.
Yeah, Zaven, what do you think about the liver abnormalities, the lymphadenopathy? I mean, we don't really have answers for those yet, I don't think.
I was just saying in the chat that I think I remember learning that Lyme is one of the sort of tick-borne doxy-deficient states that doesn't itself tend to actually involve the liver or cause thrombocytopenia, for example, and usually their presence can be a sign of co-infection, which is just super common anyway with anaplasma or ehrlichia most commonly in that part of the country. But as far as the lymphadenopathy, were you asking?
Yeah, I guess that could fit, huh? Even if it's localized.
Yeah, see that I'm not sure about. I'm also just trying to like piece together the timing. I think one of the things that we talked about in the last case of Lyme carditis is that it can occur during acute Lyme, and I'm just wondering this rash on the back of the calf, like when it was, as the patient had Lyme the whole time, and they have the whole sort of a systemic syndrome that is just kind of lingering untreated. But yeah, I think definitely possible. Yeah, for sure.
And
Right.
as we wrap up too, I can help kind of tie this to how we ended up tying everything together.
Are there other things you think it would be helpful for us to just sort of comment or reflect on before we hand it back to you, Brett?
I think, I mean, the biggest things, I think, and we kind of already alluded to it, was, a lot of times that's one of the reasons why I wanted to present this case is this is kind of oftentimes how we see things progress in the hospital, right? You get hyper-focused on one thing, don't really kind of different symptoms get played up or down. I think the other things I would have focused on or that we did as things started trickling back is this intermittent travel to his family in Rhode Island and to the Northeast, this, intermittent skin rash, whatever the skin rash was. And this was actually somebody who, And I think you see this commonly in a tertiary and quaternary health center. He'd seen dermatology for that. He had, he's seen cardiology when he first came into clinic, all these different, and he's seen hepatology, all these different subspecialists when they each got their own little snapshot, weren't really, nothing really was being put into the big picture. So I think going back, some of the things we thought of were the travel to Rhode Island, the skin rash, which was thought to be just an allergic reaction, just given some steroids by dermatology, but was several months ago prior to presentation. And then as the months went on, then developed some of this dyspnea on exertion, these pains that he personally attributed to exercise, but now looking back on it, they persisted in the hospital and were reproducible on exam, even when he was no longer exercising. So now we have different, not quite the typical, migratory, but, in a way, and definitely different, multiple different joints. So polyarticular joint pain, travel to New England, as well as kind of an unclear, antecedent rash, as well as now this high grade AV block that I think then kind of put everything kind of in more perspective. And then we can go into the liver stuff as well as we kind of wrap it up.
So easy when you just put it that way, right? Travel to New England. But I think I'm so glad you brought the case, Brett, for that reason. I think, right, it also highlights, Deborah, you reflecting on this, like what's endemic to where you practice, right? Because even, right, the subspecialist looking at a snapshot, if he had been in Rhode Island, right, there might have been a sort of quicker connection on this. So I think, yeah, that's why we love these cases, right? Hearing from different geographic regions, what can be done, and is just so valuable, right? Because we see what we see, and that's what's at the forefront of our differential diagnoses a lot of the time.
I'm reflecting a little bit on what just sort of Brett said and kind of what we're talking about of when should you zoom out and try to look at the big picture. And I think what I can think of is, anytime you don't actually know what's going on, anytime you're solving a problem that isn't straightforward, where like, okay, somebody who smoked 50 years and, is short of breath all of a sudden, you like scan their chest, it's super emphysematous, like, okay, you have a very clear pathway, right, for likely diagnosis and a plan. But anytime you're kind of lost, I think it's important to look left and right and up and down and see if things tie together. And then the other time is sometimes there's certain little problems or symptoms or syndromic features that should raise the spidey sense for a systemic disease. So to me, like, an infiltrative, like an elevated alk phos is one of those things. Or, uveitis. If somebody has uveitis, like if they develop a problem anywhere else, right, you should wonder whether this is some disseminated atypical infection, whether this is sarcoid, whether it's, something that tends to cause kind of multifocal inflammatory problems, right? So that's kind of my reflection on having sort of been a little too zoomed in and not paid enough attention to, all of the different features that were mentioned.
Brett, teach us some more.
Yeah, absolutely. So following the serologist coming back positive, infectious disease was consulted, recommended a 14-day course of ceftriaxone directly for the Lyme carditis. That was then followed by an additional 14-day course of doxy for what was presumed Lyme arthritis. And then after completing the totality of his treatment, had resolution in his myalgias and arthralgias, went back to EP clinic, where he was found to have to be minimally pacemaker dependent, and then eventually was able to have the pacemaker successfully removed. And then tying that all together just to the commentary I think some of y'all had, that infectious disease agreed that most likely some of his abnormal liver findings were a sequelae of co-infection, that he likely had some, either that rash initially or some, whether that was involved or if he had, which is not uncommon, to have missed the initial the initial rash and presentation of his Lyme, but that then in the later stages can have likely from co-infection to liver abnormalities and then kind of progress from there. So all of his initial complaints, the LFT abnormalities and everything else has since resolved and he's doing well. And I think that was one of my bigger takeaways, was that, was how you can see some of those abnormal LFT derangements from co-infection and then some of these other more delayed manifestations of Lyme. And then kind of as we said, as we already mentioned, the other big learning points were for me were taking that step back. And then also I think a lot of it too is asking, you can't, you can be the best diagnostician, but you can't figure out something if you don't have the answers, right? And so when we finally had, some of the travel history and some of these other parts, like that's how you're able to kind of piece together the whole picture.
Lyme is not at all endemic in Atlanta, right? Or Georgia at all, right, Brett? Yeah.
No.
Yeah.
Although I think there have been some case reports just with climate change and things like that, that the area, some of the geographic distributions have changed somewhat. But from my understanding, that infectious disease kind of thought so as well, that they more than likely he picked it up at some point, which would make sense timeline wise, just that it was kind of months before that he had been in Rhode Island, that was probably at some point there he had developed, he had gotten bit.
So the illness script of Lyme that we've all enhanced a little bit, I think as Deep had looked up, endocarditis is exceedingly rare, so should not really be in our kind of list of more likely cardiac manifestations, and that the LFT abnormality is like occasionally can be from Lyme itself or the co-infections, as you said, Brett. Awesome case. Deborah and Zaven, do you guys want to share just a reflection, take home point, anything, having learned some great things from Brett?
Yeah, definitely. Like, I think definitely the patient was really lucky to have him, like, because the patient went for different doctors and nobody could figure it out. And my takeaway is that I always think that Lyme, the patient can present like a flu, and then maybe can go to the heart block, or can have like a bilateral palsy in the of the nerves. But I don't think patients are the same of our books. So definitely, like what Zaven said, that look right and left, up and down, and in this case, like trying to figure it out and ask more to the patient, and don't like start ordering a lot of labs and exams and trying to find something. So yeah, thank you so much for the discussion.
Love the case. Thank you. Really great discussion and teaching points from everybody.
Yeah, really loved it. I sort of said my reflection earlier, but I have many times, right, not sort of taken some of the little aches and pains or the slight skin changes, right, that someone is reporting necessarily into the big picture, and just reminded how that's part of the zooming out process too, really thinking about all the symptoms that are there, particularly when there's something very scary and dramatic that we're working on, right? Heart block in this case, Brett. But often, a lot of the times they won't have anything to do with it, but just pausing to reconsider if they could, and if that takes the case in a different diagnostic direction. Mariana, want to take us home with some teaching point summary?
Yes, thank you very much for this amazing case, everyone. And I'll do a quick recap of what we discussed today. So we started with the patient with declining exercise tolerance, and first we had to better characterize these exercise intolerance. And we found out that the patient had dyspnea on exertion and exertional fatigue. And then we started to think cardiopulmonary symptoms versus anemia. But the patient also had liver abnormalities. With that, we could do a review with liver abnormalities in general, and we discussed 4 patterns. We can have the hepatocellular pattern when we have increased AST and ALT, or cholestatic pattern when we have increased bilirubin. We can have the mixed pattern when we have both AST, ALT, and bilirubin increased, or infiltrative pattern when we have a very elevated alk phos. And at this point, our differentials were medications, toxins, anything new that a patient had started in the past few days, family history, fatty liver disease, and celiac disease. But then we started to discuss other things. The patient also had exertional syncope, and this is a red flag for cardiac problems, both structural or breathing problems. And the ultrasound, we could notice abdominal lymphadenopathy, And when this is associated with abnormalities of LFTs, we have to think about malignancy versus infiltrative disease, such as sarcoidosis, amyloidosis, or infection. And at this point, we had so many things to consider, and then we did a problem list, and we had bradycardia, exertional syncope associated with abnormality in the LFTs and abdominal lymphadenopathy. And then with the ECG, we noticed that the patient had a heart block, and then we did an overview of what could be causing the heart block. It could be intracardiac with hemochromatosis, amyloidosis, general fibrosis, conduction system disease, or we could have something external to the heart causing the heart block, such as infection, as Lyme disease, or viral myocarditis, or severe electrolytes, or med and toxins, or procedures. And then we found out that the patient had Lyme disease, and we did a kind of an overview of cardiac manifestations of Lyme disease. Outside, we can have pericarditis extending to myocarditis. We can have Lyme disease affecting the conduction system, causing complete heart block, and whole muscle involvement causing cardiomyopathy. And we also consider in a retrospective view the knee pain that the patient had. And this is something that is very important for me that Steph mentioned it, that is in real life, we have so many things like knee pain, back pain, that when a patient appears with these complaints, sometimes we don't consider it as a signal. We consider it as a noise, but we should be considering it as a signal. So sometimes it's important to consider these regular complaints as something important too. And the main takeaway for me is the importance of the big picture. So this patient had travel history, rash, AV block, and polyarticular joint pain. And when we put it all together, we can see Lyme disease appearing. Thank you very much.
Thank you, and thanks to Deborah and Brett. And Sohail, congrats on your scribing. Such a great case, learned a lot as always, and can't wait to see you guys next time. Have a great rest of the day. Bye.